can talk about the important subject regarding neonatology, and that is intracranial hemorrhage. We have different types of intracranial hemorrhage that, of course, follow the anatomical redistribution of the hemorrhage. We have a simple and maybe spontaneously resolved intracranial hemorrhage, and we have a severe and aggressive, and each effect on the growing brain of the newborn. Subarachnoid hemorrhage, one of the important types that may occur after normal or even traumatic delivery. Bleeding, of course, is self-limited, and symptoms like irritability and seizure resolve in a few days. The infant may be asymptomatic, can be discovered in routine assessment of the ill, or even a normal looking newborn. Of course, this discovered by imaging or study. Second, subdural hemorrhage also is seen during birth trauma, and of course its effects according to the amount of the blood that accumulate and causes space occupying lesion and its pressure effect on the underlying brain tissue. Of course, this may need aspirate in certain condition, and most of cases resolve spontaneously. So we have distinct tissue damage, but we have a space occupying lesion and its effect on the underlying tissues. The most important of these intracranial hemorrhage is the intraventricular hemorrhage. Is almost exclusively in the preterm infant. As we mentioned before, in every subject, you can classify the neonatal problems for premature or term to make the issues of these conditions so easy for you. So, intraventricular hemorrhage is disease of the preterm. Of course, result from bleeding of the general matrix. Frequently after asphyxia. Of course, the hemorrhage occur in the first few days of life, and the clinical picture, of course, different in its presentation. Seizure, apnea, bradycardia, lethargy, coma, hypotension, metabolic acidosis, anemia. Of course, anemia not respond to the blood transfusion. Keep this possibility in mind. Bulging fontanelle plus continuous mottling. And the most important trait of the intraventricular hemorrhage and its presentation in the unit is repeated uncontrolled seizure, bulging fontanelle, and anemia that not corrected by blood transfusion. This is the most important trait that bring attention for the possibility of the intraventricular hemorrhage. Intraventricular hemorrhage can be classified for at least 4 grades in its severity, of course, by ultrasound or by CT scan. So infants with small hemorrhage, grade 1 and grade 2, are asymptomatic. infant with a larger hemorrhage, grade 4, have a catastrophic event that rapidly progress to the shock and coma. So the diagnosis of such problem can use ultrasound through the anterior fontanelle or CT scan, and we say previously CT scan considered the best sensitive tool for diagnosis of intraventricular hemorrhage in comparison to other imaging studies. And according to this investigation, grade 1, the hemorrhage is confined to the general matrix. Grade 2, blood noted in the ventricle, but without ventricular dilatation. Grade 3, extension over grade 2 with ventricular dilatation. Grade 4, blood in dilated ventricle and in cerebral cortex. So here, the bleeding extended for other brain tissues. Grade 4, of course, the most severe one, has a poor prognosis and thus the development of the periventricular small equiescent cyst lesion with or without porencephalic cyst and post-hemorrhagic hydrocephalus. So the bleeding can result in different brain cysts and, of course, hydrocephalus. The cyst may correspond to the development of the periventricular accumulation, which may be a precursor to the cerebral palsy later on. So the net result of severe intraventricular hemorrhage may be a cerebral palsy. As you know, cerebral palsy, it means damage to the growing brain. Of course, static damaging to the cerebral, to the growing brain. Of course, cerebral palsy equal to the crippled human being. So this is a very important subject that you should suspect in a preterm infant that develop repeated seizures, tension of the anterior fontanelle, plus anemia. Keep in mind this possibility. Of course, can be confused with other condition, but the triad make the suspicion more with intraventricular hemorrhage. Treatment of cranial hemorrhage. Of course, supportive. Start with ventilation, blood transfusion for shock. Post-humoral hydrocephalus may be managed with serial lumbar puncture that can be done daily, or external ventriculostomy tube or permanent ventricular peritoneal shunt. So when you deal with the intraventricular hemorrhage, of course, the possibility of that occurs all the time, keep it in your thought. Implantation of the shunt often is delayed because of the high protein content of the hemorrhagic ventricular fluid. Here, the permanent shunt may be delayed to avoid this possibility that may close the shunt, so we can use the daily aspiration till this possibility settled, and then insert a permanent shunt. Any question, please? Any question?
إن شاء الله ماكو دكتور.
إن شاء الله. Here we talk about other important neonatal issue, and this is the neonatal seizures, neonatal convulsion. Are not uncommon, so it's important. Neonatal seizure may be subtle. Subtle means quiet, not so obvious or not presented in the usual one with the clonic tonic. So presentation may present as a just eye movement, like rhythmic eye deviation or blinking of the lip, tongue thrusting, fluctuation of the vital sign, or even apnea. These, of course, the most presentation of the neonatal seizure. Then may follow or not followed by general tonic, multifocal, clonic, focal, clonic, or even myoclonic seizure. So most of the typical presentation may happen, but the most common presentation is not specific or even subtle sign, just eye movement, flickering of the eye, the flickering of the angle of the mouth, thrusting of the tongue, or even change in the vital sign. Keep in mind, you should think about neonatal seizure by observing of a such simple presentation. Not any movement that may be considered abnormal, considered seizure. Sometimes seizure may be difficult to differentiate from benign juterness, or from tremulousness in the infant of diabetic mother. Infant of diabetic may be complain from frequent tremoring. Also, infant with narcotic withdrawal. This, of course, happened. This juterness or benign tremor, of course, should be differentiated from the real seizure. Juterness and tremor are sensory dependent, elicited by stimuli. So you can stimulate or you can make it to be present easily after sensory touch or even moving the newborn. So sensory event help to triggering of a such benign movement. Juterness, of course, interrupted by holding the extremity. Juterness stopped by touching or holding the affected part. While seizure activity becomes as a course, fast and slow chronic activity, where juterness is caused by a fine, rapid movement. Seizure may be associated with abnormal eye movement. So, juterness, simply we can differentiate from the real fit. Juterness stimulated by sensory stimuli. Juterness can be stopped or interrupted by touching the affected part. Juterness sometimes not associated with abnormal eye movement. So clinically, by observing a such event to help you to stimulate, to differentiate between juterness and real seizure. Of course, the precipitating factors kept in mind, such as infant of diabetic mother or a drug addiction. Of course, maternal drug addiction. Etiology of the neonatal seizure, of course, we have different causes of neonatal seizure. Asphyxia, asphyxiated brain, important cause for brain insult resulting in refractory seizure. Brain anomaly, one of the important neonatal seizures that, of course, refractory to the treatment. Intratracheal hemorrhage that we talked before, important cause. Systemic metabolic abnormalities, hypoglycemia, hyponatremia, hypernatremia, hypocalcemia, hyperammonemia, and other inborn error of metabolism like amino acid or organic acidemia. Meningitis, encephalitis, and pyridoxine deficiency. Here, so important pyridoxine deficiency to ask the mother that may take a lot of pyridoxine during pregnancy. As you know, pyridoxine B6 used as an antiemetic drug besides a vitamin. So if the mother receives a lot of pyridoxine and then interrupted after delivery, the newborn may suffer from repeated fits that not respond to the treatment unless you add pyridoxine. So generally, after you exclude birth trauma, brain injury, or CNS injury, and the fit not stop, you should think and ask about pyridoxine deficiency. So maternal history, of course, crucial in this point. Diagnosis. Of course, you should evaluate and examine the infant thoroughly. And of course, you should send for surgeon investigation according to the possible causes that cause neonatal seizure. The following may be considered important in assessment of the seizure, starting from neurological examination, EEG, ultrasound, and CT scanning. If you didn't find the cause, you can send for glucose, calcium, sodium, inborn error of metabolism, of course, lumbar puncture, and evaluation of CSF for suspicion of sepsis. Important for you to start with the simplest one by sending for metabolic disorder, glucose and calcium, and other electrolytes. Then you think about the more complicated investigations. Any question, please? Of course, the treatment accordingly to possible cause. Any question, please?
إن شاء الله معك دكتور.
إن شاء الله. We can stop just to take a screen. Okay. Neonatal hypoglycemia. So important for you to know about neonatal hypoglycemia. Of course, hypoglycemia is a disaster for the newborn because the new brain depends completely on its energy on glucose. So any prolonged hypoglycemia resulting in a disaster. And of course, we getting a crippled human being. So always you think about hypoglycemia in ill newborn or even in ill elderly child or even adult. So if you face ill patient or ill newborn, and if you have 1 drop of blood, certainly you should send it for assessment of the level of glucose. Hypoglycemia is an important issue in every ill patient. So neonatal hypoglycemia is defined as a plasma glucose concentration less than 35 milligrams per deciliter during the first 24 hours of birth. First day, this is accepted level beside the condition that your newborn is asymptomatic. Of course, the level of the glucose should be raised after the first day. Hypoglycemia is a very common in infant of diabetic mother, as well as in infant who are born with a various perinatal complications. So any abnormal condition, of course, that result in hypoglycemia. Prematurity, intrauterine growth restriction, and asphyxia, of course, this is important, and accepted causes for neonatal hypoglycemia. We can talk about these conditions in brief. So, regarding pathogenesis of the neonatal hypoglycemia and its causation, we can take a maternal diabetes because it's so important issue that causing of hypoglycemia. Hypoglycemia in infant is a result of the hyperinsulinemia that persists after the umbilical cord is cut and the maternal supply of glucose is interrupted. So in utero, there is no problem. But after delivery, we have an immediate cut of the umbilical cord that resulted in different level of hypoglycemia. Prematurity, preterm infant become hypoglycemic owing to diminished glycogen store and to immaturity of gluconeogenic enzymes. So immaturity of the enzymes and less store, important cause of hypoglycemia in the premature. Growth retardation in utero. Growth retarded infant frequently are depleted of hepatic glycogen and quickly become hypoglycemic. So there is less store. Perinatal asphyxia forces the fetus to use anaerobic metabolism, which quickly depletes the stored glycogen and results in hypoglycemia. Cold stress, oxygen consumption, as well as glucose consumption, of course, leading to the free acid and result in hypoglycemia. Sepsis causes hypoglycemia, although the hypoglycemia also may be present for a while, but hypoglycemia is the most presentation regarding sepsis. of course, this happens due to poor intake and even increase the catabolic state. Beckwith-Wiedemann syndrome, it's important syndrome. And of course, we can see one of two cases in your clinical session in pediatrics about this condition that characterized by profound hypoglycemia, visceromegaly, macroglossia, and omphalocele. Hyperinsulinemia secondary to the pancreatic islet cell hyperplasia is responsible for hypoglycemia. Nesidioblastosis and pancreatic islet cell adenoma are associated with hyperinsulinemia and hypoglycemia. Metabolic, such as galactosemia and panhypopituitarism, of course, all of these can result in hypoglycemia. Of course, hypoglycemia may be simple to be treated, and hypoglycemia may be difficult to be treated. Any effect of islet cell that resulted in hyperinsulin secretion, of course, can causing a refractory type of hypoglycemia, like Beckwith-Wiedemann syndrome, nesidioblastosis. Of course, this is a most important of hyperinsulinemia beside infant of diabetic mother, Clinical features of neonatal hypoglycemia. We can classify the presentation as simple asymptomatic or symptomatic, that may present with hypotonia, jitteriness, apnea, tachypnea, cyanosis, hypothermia, poor feeding, and if not treated, resulting in seizure. So, asymptomatic, just by assessing of the random blood sugar, or symptomatic by some symptom beside level of the sugar that, of course, is than normal. Of course, we say jitteriness, of course, resulting from the hypoglycemia and even hypocalcemia. Jitteriness, of course, considered to be normal in first 2 weeks, and of course, considered to be abnormal after that. Any case of jitteriness, you should send for random blood sugar, because jitteriness resulting from the borderline or even low glucose level. Therapy. So important, and to be aggressive in assessing the newborn that's suffering from certain conditions that we mentioned, and that may result in hypoglycemia. So, infusion of the glucose considered important for a such condition. So the glucose infusion may be required for several days until the basal insulin secretion rate decrease and glycogen store are replenished or gluconeogenesis improve. So we can keep the random blood sugar with a normal till the body metabolism of the start to be improve its normal process in gluconeogenesis and activation of the other enzymes. That's so important for keeping the blood sugar within normal. Bolus infusion of hypertonic glucose should be avoided because they may result in a rebound hypoglycemia. So the important thing for you is to infuse a glucose that should be inserted or infused in a constant infusion, not a bolus infusion. Constant infusion, so important for dealing with neonatal hypoglycemia. We can start with the infusion of 6 to 8 milligrams per kg per minute. This may be increased to a rate up to 20 milligrams per kg per minute, of course, according to the severity of the problem. Central venous should be used if we have a high concentrated infused glucose, because thrombophlebitis, of course, may happen. So hyper solution that infused should be inspected carefully to use a central vein for infusion of a hyperosmolar substance. If you have a severe neonatal hypoglycemia, we can start with small bolus may be used for extreme hypoglycemia. Then this should be followed by a constant infusion. So not give a bolus and then stop. If you have a severe type of hypoglycemia, of course, we can use a bolus, small amount, then followed by a constant infusion to prevent rebound hypoglycemia. Keep in mind, hypoglycemia that is secondary to the hyperinsulinemia and resistant to the antibiotics should be treated with corticosteroid or diazoxide. Here, we use a more aggressive management for hyperinsulinemia. Of course, we can use corticosteroid and diazoxide beside of infusion of the glucose. If we have a condition that can release extra insulin, we can do a partial pancreatectomy. Of course, this leads for a syndrome or tumors like adenoma that may increase a lot of insulin. Of course, partial pancreatectomy leads for a special condition, but most of the newborn respond well to an infusion of the glucose that given in a constant infusion. So important and should keep in mind neonatal hypoglycemia. Of course, if you face a newborn that suffering from the precipitating factors of neonatal hypoglycemia, you should think about this possibility of hypoglycemia. Keep yourself familiar with the treatment of the neonatal hypoglycemia. Here, any question, please? Any question?